Unfortunately, gender is quite complicated and largely multifactorial, and much of the development of gender is still relatively poorly understood, largely because it's difficult to study living brain tissue. There clearly is a chromosomal component to gender identity, but it is not entirely chromosomal. There are XX males that if you do a karyotype, there'll be 46XX, just like a typical, quote, normal female, but they have normal male anatomy and normal male identity. Testicular feminization is another classic example where gender and chromosomes do not necessarily match. Testicular regression syndrome, depending on when in fetal development the testes regress, you can have complete sex reversal where you have someone that is 46XY but has female external anatomy and female identity. There's clearly an anatomical component to gender, but obviously in cases of aphalia, which is fortunately very rare, but there are genotypic males that are born without a penis, a penile structure, but they identify as male. They have normal scrotum, normal testes. So clearly anatomy is not entirely all. There's obviously a physiologic component. Part of the reason why with testicular regression, if it happens late in fetal development, they grow up with a male identity, they just don't have testes, is because they're still exposed to some testosterone during fetal development. We know that girls in particular are 46XX individuals with congenital adrenal hyperplasia that are exposed to large amounts of testosterone during fetal development are at risk for having some degree of gender dysphoria, gender confusion, gender discongruent behavior. And the more virilized they are some that eventually identify with complete gender identity disorder. So clearly there's a physiologic component as well. There obviously is a neuropsychological component, and that is probably the hardest to quantify and identify, largely because we're just not entirely sure which part of the brain controls that development. Gender identity generally begins early in life. Usually in the first 2 to 5 years of life is when children begin to form their own gender identity. Sexual orientation, on the other hand, tends to develop right around the time of puberty, so much later on in life. Gender dysphoria is not the same in children as it is in adults. In children, there is often some discongruence, so to speak, with gender expression in terms of play activity and peer preferences. We call that gender discongruent behavior. These are boys that might play with girl toys, they might wear their parents' makeup, they might even wear dresses. It does not necessarily mean that they will have gender identity disorder later on. Gender discongruent behavior is quite common, but very few of them, less than 1%, actually go on to develop gender identity disorder later on in life. So just because a young child may choose to play with toys that is primarily consistent with the opposite gender does not necessarily mean that they will have gender identity disorder later on in life. About 5 to 12% of natal girls, so a natal girl is someone that is born 46XX and has female anatomy, will exhibit some cross-gender behavior early on in life. It seems to be less common in natal boys. Boys are more likely to be referred. I think some of that is psychosocial, because when you see boys wearing makeup or wearing their mother's shoes, it tends to be more alarming to the family. We tend to not pay as much attention to it in girls. There does not appear to be any racial or ethnic variations. And as I said earlier, very few of those children actually go on to be given an actual diagnosis of gender identity disorder. Mental health issues are quite common. I am not a psychotherapist or a psychologist, but inevitably that becomes part of the conversation. We'll defer much of that to the second talk, but depression is quite common. Quite a few percentage of children with gender identity disorder will have some degree of depression and anxiety. The suicide rate for this is quite high. Up to 50% will report some degree of suicidal ideation. 30% of them will have true attempts. So the success rate for this is quite high. And suicide is a very high cause of death for adolescents in the United States. Substance abuse, which is largely self-medicating, is also quite common in gender identity youth. This is the DSM-5 criteria for being diagnosed with gender identity disorder. Again, I admit some some lack of complete understanding for this, because I'm not a psychiatrist. I generally tell patients and parents, this is a psychiatric diagnosis, this is what they go through. They then send them to endocrinology to facilitate the management. But this is the DSM criteria in terms of how persistent it is, how strong it is, how long it lasts, when it starts, when the manifestations and the anxiety gets worse, which tends to happen during puberty. We'll talk more about that in an upcoming slide. Some of the features: there's significant distress due to the discordance. It is not just simply feeling bad about yourself. It has to do with the stigma associated with those secondary and physical characteristics that provokes significant distress in these individuals. And this is largely what leads to this self-harm, self-injurious behavior, and suicidal ideation. As I said earlier, gender nonconformity and gender dysphoria are not the same things. Gender nonconformity is really a social concept in terms of what should a male look and act like, what should a female act and look like. That does not necessarily equate gender dysphoria. Gender dysphoria, on the other hand, as I said earlier, is due to the significant distress. Most people that have gender nonconformity do not necessarily have gender dysphoria. Some of the predictors of persistence is obviously the intensity, how young it starts. Generally, the younger it starts, the more likely it is to persist. And often when I talk to families, and these are older children, the parents will say, I knew this all along, or these are kids that argued and screamed and cried when you tried to put the dress on when they were 2 years old, and vice versa. They wanted different kinds of toys, and it was not just I want a different toy. It was more than typical childhood behaviors. In terms of treatment, in early childhood, obviously, we don't intervene with endocrinologic management. It's largely psychological support, sending them to therapists, sending them to counselors. Very rarely do children come to me before puberty. Largely it's after a psychiatrist or a psychologist has established a diagnosis, but sometimes they do come to an endocrinologist as young children, and I largely introduce some concepts and refer them to psychiatry. In early puberty, this is when the secondary sexual characteristics begin to develop. There is an indication to introduce GnRH analog therapy. It's very similar to precocious puberty. Essentially, we arrest the child as a prepubertal child. When the secondary sexual characteristics develop, that causes a lot of anxiety for these children. As the genitalia starts to change, as breasts start to develop, they become outward, and that's very disconcerting to them. I always tell patients, or parents rather, that young prepubertal children, really, if you dress them alike and give them the same haircut, it's hard to tell who's a boy or a girl. Once puberty starts, the Adam's apple starts to develop, the breasts start to develop, their body starts to change as these males start to virilize, the shoulders become broad. It's very disconcerting to them. So studies show that introducing GnRH analog therapy to suppress the pubertal changes is quite helpful for them. Later on in puberty, and when to introduce this is becoming somewhat controversial. It appears that we're introducing therapies probably a little bit earlier than what was done a few years ago, but that's when the true cross-gender therapy, in other words, introducing estrogen to a natal male or introducing testosterone to a natal female, can begin. Pubertal blockade has been shown to reduce the anxiety and depression quite a bit. And much of this has to do with the outward physical characteristics that are very disconcerting to them. The other benefit to pubertal blockade is the chance to improve height in a natal female. Keep in mind, the average male in the United States is 5 inches taller than the average female. So if you have someone that is supposed to be a 5'2" female, so to speak, but then is going to identify and live an adult male life, you'd like to get them to be as tall as possible. These are psychological studies that have shown that pubertal suppression when beginning early on, or at least mid in puberty, has been shown to significantly improve their well-being. There's a better response to surgical transference later on in early adulthood if necessary, and it allows for an easier induction of cross-gender hormones around the age of 14 to 16. The potential therapies for blockade, the one that is commonly used is a hystrelin implant. Unfortunately, it's very expensive, but there are ways to buy and bill, so to speak. It's a once-a-year implant underneath the skin that suppresses puberty. Lupron, which we're probably most comfortable with, and largely from our experience with precocious puberty, can be given once a month or quarterly. That is becoming easier to get a quote cross-gender therapy. Uh, Transgender females are introduced estrogen therapy. We slowly introduce estrogen. I generally tell them what we're trying to do is mimic normal female puberty. You cannot give an adult dose initially. That creates a lot of psychological and neurologic side effects from it. So we slowly introduce it, much in the way I would in a hypogonadal male or female. Testosterone is given systemically to slowly introduce testosterone as well. And then later on, we can transition to topical dosing if they desire. In terms of the masculinizing effects of transgender males, probably this slide largely is to discuss how soon you will see those things, because obviously these are things that they all want. A deepening of the voice tends to be one of the first things that you see. And then that comes from the thickening of the tracheal cartilage. You can see an increase in muscle mass eventually, and cessation of menses tends to happen fairly early on as well. In terms of my anecdotal experience, deepening of the voice and cessation of menses are probably the two things that they're most interested in. Facial hair tends to take a while, and I tell children all the time that developing facial hair in a male is one of the last things that happens in pubertal development. So it's not surprising that can take a while. Many of these transgender youth are not terribly interested in facial hair. It's the deepening of the voice and stopping the periods is what they're primarily concerned about. In terms of the risk associated with it, probably the most concerning risk is erythrocytosis. The hematocrit will almost always increase. And if you have somebody that's predisposed to polycythemia vera, you have to be very careful because they can get blood clots. You can see elevated liver enzymes, although that's not particularly common. Many of the other side effects down below are really long-term risks that I don't necessarily deal with as a pediatric practitioner, but there is an increased risk for cardiovascular and cerebrovascular disease. And then there's an increased risk for the GYN cancers later on. So that has to be part of the conversation with you. In terms of how often they're monitored, generally they're seen every 3 months in the first year, and then we gradually space out to about every 6 to 12 months in terms of visiting a physician and monitoring laboratory studies. The goal is to have a testosterone level somewhere between 400 and 700. If it's too low, they won't see the virilizing effects. If it's too high, paradoxically, actually see a return of menstruation because there's a spillover through aromatization of testosterone into estrogen. So I tell these males, you don't want testosterone level to be too high because it can actually cause your periods to return. Obviously, we monitor biochemical issues as well. Later on in life, if compliance is poor, particularly if gonadectomy has been performed, you have to remind them they are at increased risk for osteoporosis. And they do require the same GYN screening if the internal anatomy is still present. So I tell them if you have a uterus and you have a cervix still, they need to be monitored, even if you're not actually actively menstruating. I do recommend periodic ultrasounds to make sure the endometrial lining isn't proliferating. If after surgery there is still any breast tissue present, that needs to be monitored because there's always a risk for breast cancer. In terms of the feminizing effects, you do eventually start to see decreased spontaneous erections fairly early on. Breast development starts about 3 to 6 months later, and that obviously is something that they're particularly concerned about. Something to point out is somewhere in the first couple of years, sperm production and testicular volume will decrease. So if they're interested in maintaining some sperm for future offspring that has a genetic link with them, I always tell them you're going to have to save some of that sperm because the testes are going to shrink. Some other risks, probably the biggest risk is for clotting. The doses of estrogen are really super physiologic. They're much more so than what you would see in a normal natal female. So when you do that, there is a significant increased risk for blood clots. This can somewhat be mitigated by topical estrogen, and largely after gonadectomy, topical estrogen is used widely in the United States. Topical as well as injectable does mitigate some of the risk for thromboembolic disease. Also reminding them cigarette smoking can increase the risk for clots. Another concerning side effect is elevated prolactin level, because prolactin levels tend to increase when you introduce estrogen, so that should be monitored as well. And as breast tissue is going to develop, there's going to be an increased risk for breast cancer, so that needs to be monitored. In terms of how often they're seen, the follow-up visits are fairly similar to a transgender male. As time goes by, you generally space out the visits. The goal is to try to decrease testosterone level while increasing estradiol level. The testosterone level can be suppressed by continuing GnRH analog therapy, and spironolactone can also be used as an anti-androgen effect. It's obviously not as effective as GnRH analogs, but quite a bit less costly. In terms of adult treatment, after they reach physiologic maturation, oral estrogen can be given twice daily for a maximum of 6 milligram dosing. Vivel is a topical testosterone, as I alluded to. And IM estrogen, can be used as well as a biweekly injection. Progesterone is often given as an adjunct. There are some studies that suggest that breast tissue can be enhanced by adding progesterone as well. Prior to gonadectomy, as I alluded earlier, if possible, continuing GnRH analogs does help, largely because it suppresses the gonadal function, because essentially you're still competing with very active testicular tissue. Most individuals, most transgender males use intramuscular testosterone. It can be given subcutaneous as well, but the vast majority of patients opt for IM injections either every week or every 2 weeks. The goal, as I said earlier, is to have a testosterone level in the young adult normal range. There are topical testosterone preparations available. My experience is young people just don't particularly like it. And that holds true even for hypogonadal males. First of all, it has to be used every day, and they often forget. They don't like the idea of dealing with the paste or the gel. I do have 1 or 2 patients that have used it, but more often than not, even after trying it for a while, they prefer to go back to intramuscular parental preparation. There is a new oral testosterone that is available. Oral testosterone decades ago caused liver tumors, which is why it cannot be used regularly. There is a new oral preparation that doesn't have the same hepatic metabolism as the old testosterone analogs, so there isn't an increased risk for hepatic tumors. I have not used it because it's only approved over 18, and as you might imagine, it's quite expensive. Progesterone can be given as an adjunct if menstruation is still occurring. Progesterone has an effect of decreasing the endometrial lining, so often patients will use progesterone as well. Surgery is becoming controversial. Traditionally, has been surgery is only performed after 18. Mastectomy has been done in young people under 18, as young as 16 recently. What that will mean in the future is still too early to tell. Complete gonadectomy will never be done under 18, in my opinion, but there have been mastectomies performed in late adolescence. Generally, complete sexual reassignment surgery is done at a comprehensive center. Here in Florida, the largest one is down at the University of Miami, but I have had patients go to other places in the country. And insurance companies do actually cover these procedures. Obviously, you're not just creating external genitalia, you have to create, urodynamic normality as well, where they can void normally and not interrupt the nerve conduction associated with that. So I largely just provide information to my patients. I'm not a surgeon and I don't know a whole lot about surgical manipulation, but I'm usually one of the first places where they request information. These are some references that are from the studies that I reported. I also refer people quite a bit to the University of California at San Francisco has a very informative transgender website, and I refer patients there all the time, so feel free to peruse their websites. They discuss treatment parameters and monitoring and so on. It's actually a very informative website. So that ends our discussion. I'll take some questions at the end of our formal talk, but we will now put forward to Mr. Thomas Metzinger.
My name is Thomas Metzinger. I am a licensed clinical social worker and a clinical hypnotherapist. And I'm very excited to be here for you guys to share some insights and maybe offer some tips on how you can kind of help, be it a healthcare provider, physician, counselor, or layman, and just be able to understand where somebody who has transgender, where they're coming from. So in my practice, I've been treating adolescents who are transgender, who identify as being transgender. And so really, I've entitled this presentation, Finding Love, Peace, and Acceptance. And really, that's what we're all kind of after, those things. Love, not necessarily being a romantic love, but love in the sense of being able to be in a place where you feel like you are a part of something, where you fit in, where you feel some peace and harmony, and where you feel accepted, regardless of how you identify yourself. So somebody who's transgender has a very challenging time in this day and age, even finding love, peace, and acceptance. So this is where I can come in. This is where I can get into that touchy-feely kind of stuff. So without further ado, I'm going to pull up the presentation. Thanks again, you guys, for being patient with the technological difficulties. I'm still adapting to this new normal. Give me a second. I'll pull up my presentation. Thanks again, Dr. Hudson. And you seemed adept at pulling that up. So hopefully I can stand in line with you. And we are off. Transgender youth, finding love, peace, and acceptance. So, of course, this will be brief. And if anybody has any further questions that we don't get to answer at the end, if you'd like to reach out to me, you can visit the website, promindcenter.com, and I'll be happy to continue answering questions and being an advocate for psychotherapy and for transgender youth. These are some things that you absolutely need to know. And this is camping on to Dr. Hudson's presentation too. Suicide is the third leading cause of death among adolescents in the US. And this is still true today. I know the study was from several years ago, but it's still very, very true. And the LGBTQ community, especially in particular transgender youth, are more prone to suicidal ideation. And, you know, in my opinion, whether or not you agree with it, we can move towards acceptance of this and being able to intervene, because we can't have kids killing themselves because of scrutiny and judgments and discrimination. There are some resources out there. Of course, if you feel like somebody is in a crisis, don't be feeling like you need to be quiet or that you're going to violate your relationship with them. Please reach out and get help. Here are two in particular resources, but you can reach out. I mean, we have this wonderful internet where you can quickly get on from your pocket computer and find what you need and get somebody the help. It's okay to ask for help and to encourage someone to get help. Also, we all have our own biases. Me as a therapist, this is one of the most important things that I have to be able to check on a regular basis. And when I have somebody in the office, I don't necessarily have to agree with them to validate them, to experience what it's like to be in their shoes, to have some empathy and compassion, and to just accept that this is where they're at. So look at the lenses that you're viewing the world through, and sometimes you can remove those and put on somebody else's lenses and see how they're experiencing things. Transgender kids, adolescents that are in here, I tell you what, they're the experts, and because they have the internet, you know, good, bad, and different. There is a difference between sexual identity and sexual orientation. Of course, identity is the gender or non-gender or being fluid that they're identifying with, and the sexual orientation is what they're actually attracted to, and that may change. That may change based on what you call it. But if they're attracted to, when they're in adolescence, to a male, and they're a female biologically, but they're trans male, meaning they're transitioning into male, they may consider themselves to be gay. But that does not change who they're going to be attracted to. Just whenever they transition, that doesn't mean that they're, imagine if you just woke up a different sex one day, you wouldn't be attracted to somebody different or a different gender. You'd still be attracted to whoever you're attracted to. And then think about how our society views our gender roles. And so you can see how somebody who's transgender, whether or not they're in adolescence or an adult, how that is being impacted on, how they're being discriminated against potentially or judged, that they're not falling into the gender roles that we have grown up with and have, placed or categorized in our mind that this is what is appropriate behavior for somebody who's a man or somebody who's a female. There we go. All right. Here's a resource that I have used, Standards of Care for Health. And this is something that would be advantageous for you to look at. This was an old, couple years ago, seminar. But there's a lot of other resources. This is just one that I happened to gather that I use some of the knowledge from this book. And so I'll just keep brushing through some of these slides for time. This is practice guidelines for endocrine treatment. This is just another thing that I was able to use as a resource. And this slide talks about some of the lingo. This has been important for me. Now, this is not a comprehensive list, but I'll just run through a few of these. There is a lingo or a language associated with being transgender, and that's important to kind of identify or at least ask the person what things mean. Don't be afraid to ask. In fact, if you have somebody who's transgender that you're treating, they would like for you. The clients that I've had really enjoy that I'm taking an interest in that and asking, well, what does that mean? There's LGBTQ, which stands for lesbian, gay, bisexual, transgender, and questioning. Transgender, of course, meaning that somebody is identifying with a different gender than they were biologically assigned or born with. Cross-gender, variant, non-compliant, non-conforming, and all these have a kind of a different meaning and a way that they present themselves and the way that they identify themselves are. Gender fluid means that they can, whatever they're feeling that day, they can switch back and forth. Cisgender, meaning that they are expressing or identifying with the gender that they are biologically or that they were assigned with. And then they can express themselves wearing certain clothes or behaving in a certain way. And of course, trans male or trans female. Trans male meaning that they're transitioning into male, or trans female meaning they're transitioning into female. This is sort of some differences that I like to throw out there. Since I'm a social worker, psychotherapist, I like to kind of throw that from my perspective. I look at the person in the environment. And I know that physicians do, the medical community does too, but this is sort of, I'm taking all of these different pieces and parts and really putting it together to try to come up with a way to help somebody cope with life, to learn certain skills. So we're looking at how they're functioning and at home, at school, at work, with their friends, with their parents, in relationships. And I use evidence-based practices. And the number one intervention style that I use is cognitive behavioral therapy. And I use that in conjunction with hypnotherapy. But cognitive behavioral therapy is one of the most studied and has empirical evidence that it really helps in a lot of different mental illnesses. And the medical model being just slightly different, where the medical model is looking at signs and symptoms. There are medical experts who are using treatment protocols based on clinical trials, using evidence-based practices as well, and identifying something that is wrong, where it's maybe a little bit more reactive, and then treating that. And this is where maybe some controversy exists, because if somebody physiologically is okay, if everything tests out, now I'm not a physician, so I can't speak intelligently on this, but um, why would we need to intervene? Well, the reason why is psychological and psychiatric reason. Sexual identity. This is something that was taken from a Nemours article. And this is, I thought, really profound because it's showing that around age 2 or 3, this is when a child actually starts to become aware of their gender and what gender is, and then gender roles about themselves, just to be aware of the messages that are being sent at home and then out in the community. And then when somebody comes into the office, we do a their speech and their language, their mood, their affect, maybe their intellectual functioning, their insight and judgment, whether they're homicidal or whether they're suicidal, the content of their thought. And then that moves us into actually coming up with a diagnosis. Now we use the DSM-5 currently, the Diagnostic and Statistical Manual of Mental Disorders. And so this next slide, I have a match up what they're saying and how they're behaving with some of the criteria. And I want to make sure that they are safe. That's the number one. So we manage any crisis that they're currently experiencing, whether it's at home, whether it's in their neighborhood or out in their community. If there is any current violence that's happening, do I need to get other authorities involved? Make sure that they have adequate living conditions and that they have some sort of support. Also looking at maybe their hobbies and their recreations, what's going on, what kind of friends do they have, what's that social scene look like, how are they able to relax, what are they interested in, and what kinds of things do they do out in the community. Also looking at how they interact socially, and discussing their friendships, their support system, their relationships with their family, and their communication and social skills. Interestingly enough, um, the kids that I see, I usually have to tell them to put their phones away because they can't stop looking at, Snapchat while they're in the office. Anyway, and then this is where my expertise lies. I work with a lot of trauma, PTSD, anxiety, and depression. And you can imagine that with transgender adolescents, their anxiety and depression increases. And then the traumatic levels also increase because of scrutiny, judgment from their peers, from their family, lack of support, lack of being able to fit in places. And then that continues through a lot of their lives. And so I like to do trauma and understand maybe some traumatic events that have happened in their life, or we all experience trauma in one way or another, but it's how it affects us, as to how we're actually coping with it. So we look at the psychosocial impact of trauma on their current lives, looking at physical, emotional trauma, sexual abuse, and how that manifests itself in maybe nightmares or flashbacks, or certain events that take place that trigger a regression or back to that period of time where they felt vulnerable or they felt abused, or when they were traumatized. And then the physiological things that occur, maybe they go into that fight or flight response when they're not in any real danger. And of course, and Dr. Hudson had mentioned this, that there are transgender adolescents are prone to substance use disorders. I mean, they're being faced with traumatic events, with judgments and scrutiny and bullying at school. And that's why I use cognitive behavioral therapy, because it's attacking their negative thoughts and their negative thought processes and teaching them cognitively ways that they can turn their thoughts around, that they can be more positive, and that they can be more productive despite others' judgments. So we'll look at their substance abuse, for example, and maybe try to find something else, a more positive coping skill that they can engage in that doesn't involve substance abuse. You know, here we go. So, as I was saying, depression and anxiety symptoms are probably the number one thing that I have to combat and help somebody deal with in the office. There are so many comorbid illnesses that coincide with gender dysphoria, and so that's where I really attack what's going on, what is the immediate crisis, and how can we help the person, the adolescent, actually deal with the things that are happening. There may be, aside from just depression and anxiety, maybe there's some schizo types of things that, like hallucinations or delusions, issues in their thought process. Now, this is not as common for somebody who comes in who is identifying as trans. Um, and there's the issues are, how is their mental health or mental illness impacting their ability to function in life, to take care of themselves, to function at school or at work or in the family system. And that's what we really want to be sure of, is that somebody is able to actually function. And when they're not able to function, that's where, I have to really focus my attention. So then we look at risks. Suicide. Remember, we talked about how high that is among adolescents, and specifically among adolescents who are transgender. And then self-harm. Sometimes I spoke about the borderline personality and the self-harm. Sometimes kids are self-harming and striving for attention because they don't feel loved, or they don't feel accepted, or they don't feel like anybody's paying attention to them. And so they may engage in self-harm, and they may continue to up the ante, and they may off themselves without even, not that they were trying to, but it just sort of happened. So this is the number one thing. The number one takeaway is the suicidality, the suicidal ideation, and not taking that very lightly, but making sure that you get somebody help. That crisis intervention is on the way. I talked about some comorbidity, and really that's where I spend a lot of my time, is dealing with depression, anxiety, trauma, and substance abuse. And then also the family. I like to take a look at what's going on with the family itself, because the family can exhibit some functional dysfunctions, and that is keeping the person, what we call the identified patient, in that patient role mentality. Almost like subconsciously, the family does not want the person to get better, so they can sabotage treatment. Here are some psychosocial stressors at home. Now, we said that there's ones at home, at school, out in the community. Just a lack of support, lack of trust, lack of communication. At home, there may be some generational patterns or predispositions to mental health or to transgender. And so to look at those types of things. Also, stressors at school. Bullying is probably one of the biggest things right now, especially with transgender adolescents and not fitting in. Um, Teachers even have their own bias, and some teachers really express that bias. And then this overall feeling of discrimination. Out in the community, when transgender adolescents or youth are out there, they are still subject to judgment. Imagine if you see somebody who has the features of a female, but they're clearly dressing and identifying as a male. That doesn't necessarily fit in our minds with what we, understand to be true. I mean, that's how our minds work. We need to, characterize things and organize things and rationalize things and put them into boxes. And this is based on our upbringing, our learning. Also, culture has a role in that. And so when we see something that's out of that normal, we don't know what to do with it. It gets kind of messy. And so we may fight back against it, or we might sort of discriminate against it. Not that we're purposely trying to do that, but it just, something that doesn't make sense to us. Then we also have our identified gender roles in our society, which we talked about before. And we want things to kind of conform to that social contract that you're you're this way and this is the way that you should act. And that makes us feel safe and secure. And when things are not that way, it makes us feel unsafe and not secure, much like this virus situation happening right now. Huh? So here's some of the intervention strategies that I use. Once again, primarily I do one-on-one counseling and psychotherapy in the office, and I use cognitive behavioral therapy, and I use hypnotherapy too as an adjunct to that. But the goal is to increase coping skills, communication, and social skills, their ability to change their thoughts and thought patterns and handle adversity, and be okay so that when things become chaotic, they don't immediately go to being suicidal. I do family therapy a lot in the office, and this can be in intense session because I'm not necessarily trying to change minds of the transgender youth or change the minds of the family members. I'm just trying to move towards uh, some support at home, not necessarily agreement, but at least just an acceptance at home. Because if you can't feel accepted at home, if home isn't your safe place, then where can you feel safe and secure? So very important for somebody who is transgender to find a place where they fit in, where they feel loved and accepted, where they do have support, is tremendous for being able to figure out, well, I have a strength in this area, but you might have a challenge and I can help you, and vice versa. Where you have a strength, I might have a challenge. There are community resources. Please look up what community resources there are in your community so that you can refer out, so that you can encourage somebody to grow and get help, and tonight not isolate and keep to themselves. Here are some psychiatric interventions. We refer out to endocrinologists like Dr. Hudson, to other medical professionals who can look at different areas that we determine may be out of our scope of practice. I do psychotherapy and talk therapy, which sometimes that's just helpful for somebody to vent about their frustrations, and maybe we can start putting pieces together that you're behaving or thinking in such a way because of something that happened to you, around age 3 or 4. And just not that we're always going to find the causation, but at least it can help the person gain some insight. I like to use hypnosis because it has an overall relaxing effect, and then offer clinical suggestions to the person that they are okay, that they are safe, that whenever they feel anxious, they can use that energy. They can rationalize things. They can feel stronger and able to handle situations. And even though their conscious mind is saying that, no way, I'm not going to be able to do that, their subconscious mind may readily take that in, and they might find themselves able to handle situations more appropriately and more effectively. And of course, psychiatrists use, because they're treating the comorbid issues, mood stabilizers or antidepressants or anti-anxiety medications to mitigate some of those symptoms so that they can actually function and there's less impairment of functioning. And for this was Dr. Hudson, his presentation. These are some intervention strategies that I had for that were medical. He expanded upon those: hormone blockers, cross hormone surgery, and he did a much better presentation about that. So, anyway, and then some nurses. We may have some nurses here, healthcare providers, just monitoring their symptomology, because that's what we're treating. We're treating the signs and symptoms of what's going on, being educators, being liaisons between the physician, between the family, and advocating for the patient, being compassionate, using just positive regard for the person, using them as the expert, knowing that if they are in the right environment, they will grow in a positive direction. There is a lot of news about transgender, especially in the military. There's actors and actresses and politicians that we can look to, and they can provide more understanding and insight, much more than I can. So there are a lot of resources out there. In fact, I've listed a couple at the end of this thing, but not enough time for you to write all those down. But in closing, it's important that we bring awareness to ourselves and to our community that whether we agree with it or not, we can move towards acceptance that this is something that's happening, that we have the opportunity to be agents of change, that we can prompt change in our own lives and with our own families and within our community, because we want to stop people feeling left out and people feeling like they need to commit suicide because there is no other way. To educate ourselves and each other, to advocate for those who cannot speak for themselves, and to display unconditional positive regard that if people were in the right environment, they would have a desire to grow and improve, just to maintain an air of non-judgment. So, and that's where we find the love, peace, and acceptance. So thank you guys so much for being here on a Saturday and for letting me talk to you. And I look forward to continuing to help out. So thanks so much.
Now we're going to have some Q&A. I do have a couple of things that I do want to say that they've been on the chat. And I guess this goes to you, Tom. I know in the definitions that you gave, someone is asking, could you explain the meaning of queer? How is that
Queer.
used, terminology?
Queer used to be LGBTQ used to be the Q used to be queer, and I think that was just more questioning is a much better term that has been accepted in the LGBTQ community. Queer was just sort of like we're not really sure. We are in fact questioning whether or not we're versus our identity and versus our orientation too. So I hope that that helps kind of answer it. It's transitioned into questioning now.
Thank you. Thank you. I appreciate that. And this came, there were some comments and questions from Carmen, who is a pediatric endocrinologist in Argentina. And I will probably pose this to Dr. Hudson. She is saying that she does treat transgender children and adolescents, but the majority of them don't want to preserve fertility. She was saying that there's no public place to do this, and they're not, I guess, worrying at that point about future children or, you know, in your experience, she'd like to know how many transgender male or female choose to preserve fertility.
Excellent question. Very rarely. It's largely, I introduce this as a concept if they've thought about it. The vast majority of young people that I bring it up to are not terribly interested in it. If they are interested, I generally refer them to reproductive endocrinologists that can salvage and store eggs or sperm. But I agree with you, the vast majority of them are not terribly interested in it.
Thank you, Dr. Hudson. This question as well I'll pose to you. Donna is asking, do you have many patients who request Testopel? That unfortunately, Endo Pharmaceuticals has experienced an extensive national backorder. Just curious if this is a requested therapy by some of your patients.
No, not usually. Here where we are, we very rarely are we able to get the GnRH analogs approved anyway. So I haven't had them specifically bring it up. Most of the blockade, so to speak, that we use in transgender males is really progesterone to help stop menses. And then in the transgender females, I use a lot of spironolactone. And I actually probably have more success than my colleagues with spironolactone. I've been able to get testosterone levels down to almost unmeasurable levels. So,
thank you. Carmen was also asking, how many transgender children or adolescents have psychiatric disease that you experience? I guess this is for both of you.
Yeah, I think almost all of them have depression and anxiety. So if you're counting that as a psychiatric disease, I would say almost all of them do. Other comorbid conditions, very rarely, and the vast majority of children that I talk to, what the psychiatrists tell me is they attribute all of the anxiety really to being transgender, and many of their symptoms improve after being accepted, so to speak. And once you start treatment, many of them actually stop taking their antidepressant and anti-anxiety medications because they feel that all of their symptoms were attributed to that. I don't have much experience with kids that have other comorbid psychiatric conditions, bipolar disorder, personality disorders, and so on, or even schizophrenia. I think one of the things that most of the psychiatrists have talked to, one of the things that they try to tease out is making sure there aren't any other confounding variables that might limit the ability to establish a diagnosis of gender identity disorder.
Thank you. So I guess this question is coming from someone in our audience that says, is much of this affected by faith, religion, or cultural background, and by these children and or families? Also, how much does the background and beliefs of the treating medical staff? This is a great question. This is something we deal with all the time.
Yeah. Tom, I don't know if you want to speak to that. I'll give you a chance to kind of speak to that because that may come up with you as well.
Sure, that's a great question. So to recap, this is, oh goodness, how much of this is affected by faith, religion, or cultural background by these children and or families? Also, how much does the background and belief of the treating medical staff? Well, this is important and had touched on it in the presentation where we need to check our own biases and our own cultural histories, because culture does play a huge role, and faith and religion, because this transgender does not go along or coincide with a lot of cultural experiences and a lot of faith and religion. So this is why transgender youth especially are subject to judgment and discrimination throughout their entire lives, and why they all have seemingly other diagnosed comorbid psychiatric disorders because of that. And especially the family of origin, if their culture dictates that this is not something that is okay, that we believe in, or our religion does not promote this, that this is something that is not good or goes against God or our beliefs, then they don't feel safe, or they're gonna try to urge the kid to go through an exorcism, or to have somebody treat medically or psychiatrically to rule this out, or to stop this from happening, or maybe go to a boot camp that's gonna keep them from being gay or transgender or what have you. And so you can imagine if you're faced with that and you really feel like you are not born the right sex, I mean, where do you fit in? Where are you ever going to be accepted? So that it plays a huge role. I don't know if that specifically answered the question you were looking for, but the medical staff, I think we have to put our own beliefs and our own ideals in a large degree off to the side. And like I said, not necessarily agreeing with them, but being able to treat, so that, if I can intervene and they can have a better quality of life, I'll do what I can, because I'd rather not see them commit suicide or just be a criminal or in and out of the system, or, if I can help. No, I'm not going to do anything that I don't feel like, that I feel would be unethical, of course. So if there's something that I don't feel comfortable with, and I'm sure Dr. Hudson would agree, we refer out to somebody else if we just don't feel like, we can handle that, or our own biases or our own beliefs are too strong, that we would refer to somebody else.
Thank you, Tom.
Just to kind of piggyback on that, obviously the moral and ethical dilemma is inevitable in something like this, but this then also becomes kind of a social conversation, which I try not to have. I tell people I'm not trying to create social paradigms here. I'm trying to keep kids from killing themselves, quite frankly. I don't bring personal religious beliefs into the conversation in the patient setting, regardless of what the patient is that I'm seeing, regardless of the diagnosis. I do know there are some pediatric endocrinologists that do not treat transgender youth specifically for their own religious beliefs, and they simply send them to somebody else, as Tom just said. I'll tell you what Dr. Norm Spack up at Boston Children's, and when I first started treating kids, he wrote most of the pediatric, or was one of the lead authors of some of the pediatric guidelines for our society on this. And when I talked to him many years ago, he's actually a very religious person. And he said to me, quite frankly, he said, Omar, they're made in his image too. I found that to be a very profound statement coming from somebody that's very religious. And, you know, the reality is what we're trying to do is keep kids from killing themselves. And if I can help them in any way, then I'm happy to do that. The religious beliefs from the family, unfortunately, does, well, not fortunately or unfortunately, it's inevitable that that's going to become part of the conversation, especially because we're dealing with minors, and if parents don't consent to treatment, I can't actually treat them. And I've had that come up, and I've had plenty of patients say to me, I'm just going to come back to you when I turn 18. And in that situation, I simply try to support them psychologically as much as possible, make sure that they're getting good psychiatric help, psychological counseling, and that they're not harming themselves. And I tell them, if you ever feel like hurting yourself, please call me. I'll get you to a crisis center, or maybe you can just talk and vent, so to speak. And that's largely how I support situations like that. In my experience, though, over time, many of those parents that were apprehensive eventually come around. And I think a lot of times they begin to realize, okay, this isn't going away. This is not a phase, so to speak. And then they come to me and they say, well, I'd rather you treat them than have them kill themselves. And that I have that conversation probably half the time with many of the families.
Thank you. Our next question from Nitin is, when should GnRH agonists be stopped in trans male treatment?
Okay, that's a good question. In an ideal situation, the current guidelines and recommendations say you continue GnRH analog suppression until gonadectomy is performed. That's not always financially feasible. So if that's not the case and you have to stop it, you would like to be able to at least get the child old enough to where you're introducing cross-gender therapy. In other words, if you start GnRH analog therapy at age 10, you can't obviously start treating with estrogen or testosterone then. Once you introduce that therapy, then you may have to stop it. But in an ideal world, you would continue the GnRH analog suppression, the pubertal blockade, so to speak, until gonadectomy is performed.
Thank you. And from Veronica, we have, do you see more male transgender natal female than female transgender adolescents? And do you have a reason for that?
Yes, we do. And most of my colleagues, my friends that I talk to, I have a friend of mine, she and I were residents at USF together. She has a clinic in San Diego, and she said the same thing. We see far more transgender males than females, and it's not entirely clear why. There's so much of this and how the brain develops that we just don't simply understand.
So the other question is, another Veronica is asking, do you use the GnRH agonist in post-pubertal adolescents previous to the cross-gender treatment? If yes, how long would you use them?
Again, as I was saying earlier, you would continue that as long as until gonadectomy is performed. There have been a few cases where I use GnRH analog later on. For example, if you have a transgender male that is still menstruating despite having appropriate testosterone levels, using progesterone is just not working, then you can use GnRH analog therapy. So that's been done as well.
Thank you. And I know we had asked about the preservation of ovum and sperm, but someone is asking, Bianca is asking, how is the process for sperm and ovum conservation, and when is it best for both genders?
So there really is no specific time as to when you can do it. It's not that different than preserving ova and sperm for cancer therapy when you know that the cancer therapy is likely to damage the gonads. The extraction process is the same. Obviously, it's more invasive to extract ovum than it is to extract sperm. You know, the age that mature sperm start to develop is variable from boy to boy. It's usually about 14 to 16. And that's earlier than you would normally be introducing estrogen therapy anyway. So you can salvage sperm and store it that way. Obviously, extracting ovum is quite invasive. So you'd have to go to almost a surgical process to have that done, but it can be done not that differently than when you do it in an adult. Extracting ovum really technically can be done at any age. They would probably never do it in somebody under 16, but because immature follicles aren't that different in a prepubertal girl than it is in an older girl. So they've been preserving ova and sperm, primarily ova, in natal females for oncology therapy for quite a long time. So the process isn't any different.
Thank you, Dr. Hudson. The question is posed also by Nitham in reference to serum testosterone levels. Are we checking those in trans males just before the next injection or midway between the injections?
Obviously, some of it is variable depending on the treatment interval that you're using. When I use therapy every 2 weeks, I generally do it midway between an injection. Obviously, if you're doing sub-Q every day, it doesn't really matter. If you're doing weekly injections, you probably should check trough levels. Same thing if you're doing topical, it doesn't really matter when you do it. So the timing of when to order the blood to follow testosterone levels is largely dependent on how often you're giving it, and only really relevant, for biweekly injections.
So I guess this could be posed. Thank you so much, Dr. Hudson. I guess my question I would pose also to Tom, because I think we have covered in some of your discussion already some of these questions that are coming through. But could you tell me, Tom, when you are presented with a child, an adolescent, perhaps, that is coming in to chat with you, do you find that there is a very honest discussion most of the time? Because I know sometimes we find it's really difficult to get information out of young people sometimes. It seems to be when they finally are willing to talk, you then find that they have been bullied and there are other things that they're thinking about that their parents had absolutely no idea about. And needless to say, we find that sometimes it comes of great news and information to parents when they finally do divest themselves of that information. So in your experience, what would you say?
Maybe they have explosive disorders, or or being more some displaying some conduct disorder too, and so they bring the child or the adolescent in to be fixed and assessed and treated, and then so they'll be better. And then so I use the parent, because of course they have to consent to treatment, like Dr. Hudson was talking about. So I have to kind of be able to side with them a little bit to gain some collateral information as to what's really going on. But I express to the parent that your child, you're giving permission, consent for me to treat them, but I'm going to be their number one advocate. You have to build a rapport in a relationship, and it might take several sessions before I really start to get to the meat of what's going on. At first, they're of course minimizing things that are going on in their lives. This is very typical. That these aren't real issues until they start to really feel comfortable. And then once it's out there, once they say, I feel like I'm a girl, and I don't know how to tell my family, I don't know how to, I'm going to be perceived, I don't even think my friends are going to be accepting of it, then we have to work through them and we have a discussion. And typically the parents are not necessarily on board with it. And Dr. Hudson said this too, eventually, because they love their child and they want their child to be okay, that they begin to kind of accept it. And then, okay, well, what do we need to do? And I don't like calling it gender dysphoria, but that's just the diagnosed, in the DSM. But they're still a person. They still need love and attention and to feel like they're part of something. And so, anyway, yeah, I think I'm just kind of rambling on.
Thank you. No, I really appreciate it. I guess for a last question, I think sort of segueing off of that, and I know that we've experienced this before in practice. I guess I pose to you, Dr. Hudson, what do you do if one of the parents accepts and the other does not accept treatment of their child?
Yeah, that one's tough, and that does happen from time to time. The way I approach to the child and the parents is, if the other parent has not had their parental rights severed, I can't legally treat them. So I refer them back to family therapies, and I will talk to the psychiatrist, and I say, it's not necessarily your job to convince this other parent that does not agree. It's a job to try to educate them and present information. More often than not, over time, they do come around. But if the other parent absolutely refuses, I can't legally treat a minor.
Well, I'd like to wrap this up and thank our wonderful speakers today and for everyone who attended our webinar. I'm very appreciative for you to have taken your time on this day, and thank you again. If there are questions that we did not explore, I will be more than happy to send those to our speakers and certainly get answers back. I thank you so very much and appreciate it again. Thank you again.